Hello, everyone. You're all very welcome. My name is Aisling Hennessy, and I work here at Global Heart Hub as our Patient Community Engagement Associate. I'm delighted to welcome you today to our Empower webinar. As many of you know, Global Heart Hub is an alliance of heart patient organisations and patient advocates working to create a unified global voice for those living with or affected by cardiovascular diseases. Today, Global Heart Hub is partnered with Heart Sisters to deliver this webinar. As many of you know, dismissal is a term used to describe feeling unheard, ignored, or invalidated during an interaction with healthcare providers. It can happen to anyone, but very commonly happens to women. Heart Sisters and Global Heart Hub have been working alongside our advocate community to draw attention to the challenges women face as a result of being dismissed. For this webinar, we're going to focus on the tools and strategies you can implement to identify, prevent, understand, and mitigate being dismissed on your medical journey. Just a quick housekeeping note before we begin. Automated translated captions are available in over 35 languages by clicking the caption button at the bottom of your screen. With that, I'm excited to introduce you to our panelists. We are joined by Karen Padilla from Global Heart Hub, who will give us a foundational understanding of dismissal and what it and will discuss the role our advocate community has played in addressing dismissal. And Karen will also discuss our recent Women's Heart Health Action Agenda. We will then hear from Maggie Simpson, an experienced cardiology nurse with a particular interest in women's heart health across the life course. And Hyvel Ferguson Davis is a patient advocate who leads Heart Sisters' incredible efforts to address the gender gaps in cardiovascular care. And finally, Renata Cal-Populars is a patient advocate whose expertise has been instrumental in the development of Global Heart Hub's Women and Heart Disease Action Agenda. And without any delay, I would now like to introduce Karen Padilla, who will help to set the scene.
Thank you very much, Aisling, and I am incredibly excited to be part of this session today. Thank you very much for the invitation, and it is my pleasure and honor to share with you a little bit of what our incredible community has been doing and working on in the last couple of months that really will help us set the scene to this wonderful discussion that we will have today. And I must say, I'm also incredibly honored to be part of this panel of experts. And I'm really looking forward to the conversations. And I always learn a lot from all of the panelists. So I'm really excited about that too. Perhaps to share with you a little bit of background. As many of you know, last year's Unite shed a light on women's cardiovascular health, and it was an opportunity to bring together people with lived experience, as well as clinicians, policymakers, key opinion leaders, to really look at all the challenges and barriers that we currently see in women's cardiovascular health and the pathway that many of us women have to face around the world and in different conditions. And the idea was to turn this insight into action and improve the treatment and care for those women living with cardiovascular diseases around the world. The summit was attended by 200 delegates from 37 countries, and the whole idea was to elevate patient voices, facilitate learning on the key challenges and opportunities that we have to improve outcomes for women. Of course, the idea as well was to build cross-stakeholder consensus so that we can really affect change. And we know that in order to do that, we all need to work together as a collective. And of course, we need to identify for that the actionable priorities that we need to take. And as we do that, we will, of course, also strengthen the global partnerships that we have. And now I am absolutely thrilled to share with you that last week we officially launched the Action Agenda, which really was developed through a rigorous, inclusive, and transparent co-creation process, um, shaped by lived experience and clinical expertise, including the comments and the recommendations and experiences from everyone who participated at the Unite Summit, as well as from our Women and Heart network, an incredible group of patient organization leaders who focus on women's cardiovascular health, and who also very generously provided us with their insights, recommendations, and support to bring this action agenda to life. And as you can see, the action agenda, and I know that my colleagues will share the link in the chat. You could have it as well on the slide. This action agenda is focusing on 5 core areas for change. As you know, policy, funding, and accountability is really important and vital so that we can ensure that women around the world have access to early detection, timely treatment, and also post-intervention care that we know that is also so important. And we know that that will require health systems transformation. And it all starts with medical education and workforce development. The more we educate on sex and gender differences, the better outcomes we will have. And of course, that also starts with research and data equity. And that's why disaggregated data on sex and gender in clinical trials is so important, as well as including more women in research. We know that that is also a huge gap that we're delighted to see that it's being addressed in recent years. And as well, the participation of women as researchers is also key to ensure equitable and access to research. I forgot the word that I wanted to mention. And last but not least, and perhaps one topic that we will be discussing broadly during this hour is the importance of public awareness, engagement, and empowerment. And we know that that is a tool, and that is not only vital, but it's really at the heart of what needs to happen in order to affect change. So why this matters? We know that when women don't recognize symptoms, they face stigma or distrust system, delays escalate and outcomes worsen. So awareness that is culturally relevant, emotionally safe, and it's also a life course long. It will be essential also for the early action that we take. And the earlier we detect heart conditions, the better outcomes and the better options that we will have. So in terms of the changes that are needed from a health system perspective, the first one, of course, is to normalize women's cardiovascular symptoms and life course risk. And as I was mentioning as well, embedding cardiovascular education across adolescence, reproductive years, pregnancy, postpartum, and menopause is key so that we can detect the risks at an early stage and also accompany women through their life course. Co-designing culturally relevant messaging with the community voices and trusted messengers is equally important. And we know that patient organizations around the world are key as well, key partners in this action so that we can really have messages and coordinate actions that are not only relevant, but that make sense to the different communities. And of course, mental health awareness is absolutely vital in this process. And that's something that we have heard too many times that is often left aside when we think about cardiovascular disease. And the key area for me and the key message that I believe we all should be thinking about is that we are talking about a human being, and it is not we can't treat the body exclusively. We also need to treat the mind, and of course, nowadays we have different tools like digital tools that are accessible, that can provide us with plain language, summaries, etc., that can also make all this information, the relevant, timely information, also useful and accessible to the general public, and not only patients, but also family members and caregivers. And another very important aspect that we can all contribute to change is by amplifying the lived experiences storytelling to shift the norms and reduce the stigma, because we know that this could happen to any one of us. And once it happens to someone we know or to ourselves, then the statistics really become very personal, and we are no longer just a number. And our strategic commitment that came out of this action agenda is that we really want and we can make women's cardiovascular health visible and culturally resonant, empowering every woman in every community to recognize symptoms early and seek timely care. And as we will be hearing in the next presentations, we have, as a patient community, a lot of resources available, and I would really encourage you, if you or someone, a family member or a friend is going through any difficult time or has been recently diagnosed with a cardiovascular disease, I would really encourage you to seek help. You can really try to engage with patient organizations in your community who are doing amazing work and who will be able also to provide you with the support that you need. No one needs to walk this journey alone. And there are incredible initiatives and incredible support programs, such as the Women at Heart peer-to-peer support program, which, as you can see on your screen, is delivered virtually now, and it is led by trained peer leaders with lived experience, offering a safe and supportive space to connect, share, and learn. And it really combines emotional support with practical education, helping participants build confidence, reduce isolation, and better navigate life after a cardiac event. And this is one of many programs that patient organizations from around the world are putting together to support every patient in their journeys. So the bottom line and the message that I would like to leave you with is we are all in this together. There are resources available, and there are a lot of patient organizations doing amazing work, as we will hear in a moment, as well as patient advocates working tirelessly to improve outcomes for women. Thank you very much, and I'll hand over to you, Aisling.
Thank you so much, Karen, for setting the scene there and giving us an opportunity to really understand the impact advocacy can have in driving change in our health systems. I'm excited now to hand over to Maggie, who will offer some additional insight into dismissal, how we can prevent it, recognize it, and how we can take action when it happens. So over to you, Maggie.
Thank you. So that was an excellent introduction to this important topic, and I'm delighted to see so many people from across the globe have joined us today, because unfortunately, this is not just something that affects one small part of the world, it affects women everywhere. And I'm going to talk a little bit about approaches to preventing and addressing dismissal. There will be some overlap with what we've heard, but I think that's okay because it is such an important topic. So I'm going to look through why dismissal matters in women's health, the clinical and emotional consequences of dismissal, and then practical approaches both for healthcare professionals and for the public. So when I talk about dismissal, I'm not talking about rudeness or intent to harm. I'm referring to a pattern where a patient's concerns are minimised or symptoms are explained away without a proper assessment, often attributed to stress, anxiety, hormones, or lifestyle. And critically, where that then leads to delays, so might be a delay in investigation, a delay in diagnosis, a delay in treatment. And it can be a single moment on a woman's journey, or it can be a built-up pattern across years of consultations. And before we look at the data, I just wanted to share what we see often on social media. So these are real posts from 3 different social media channels. We can see here, being a woman is having to take a man with you, so they take you seriously. I take my mum because she'll speak up when they try to dismiss me. And these feelings aren't rare. The Mumsnet report found that 58% of women believe that the National Health Service in the UK is institutionally misogynistic. So that's not a fringe view, but really reflects patterns that hundreds of thousands of women recognise. And then we had this example here. What's a clear example of medical misogyny you've witnessed or experienced? And very quickly, there's been 123 million views of that post with significant engagement with people sharing their stories. And so why is this all relevant to heart disease? Well, we've had an excellent summary already, but we know that heart disease remains a leading cause of death for women globally. It's responsible for 35% of all female deaths. Yet, despite that, the Lancet publication here clearly shows that women's heart health remains understudied, under-recognised, underdiagnosed, and under-treated. Women are also underrepresented in clinical trials. So dismissal doesn't just happen in a vacuum, it happens in a context where the knowledge base itself even has gaps in it. And I'm going to bring in kind of medical misogyny and systemic bias. I'm not describing here a malicious intent from an individual healthcare professional, but really structured patterns. So conditions affecting women maybe being described as low priority or poorly understood. Pain and gynecological symptoms are routinely normalised. Women who report doing more emotional labour just to be believed, maybe rehearsing symptoms before an appointment or bringing someone along. And the intersectional impact is quite significant. And this experience is even worse for women of colour and underserved groups, which we'll come back to. And so in cardiology specifically, dismissal is unintentionally built into the system. I'm not making excuses at all throughout this presentation, really just highlighting reality, the fact that most of this is unintentional, but we'll look at what we can do about it. So when we look at our guidelines for heart disease and some of our pathways for how we assess and diagnose conditions, they were predominantly developed on a research base of white male populations. Life course risk factors that affect women, pregnancy complications, polycystic ovarian syndrome, things like early menopause, are often not integrated into cardiovascular risk assessment. And then added on top of that are the things that do affect everyone: time pressures in the system, fragmented pathways, and a real lack of sex-specific training mean that symptoms are repeatedly attributed to something else other than a possible cardiac event. And what's the consequence of that for the woman? Well, they don't just end in that moment when you're interacting with a healthcare professional. Women who are dismissed typically experience self-doubt, question themselves asking, am I overreacting? Am I wasting their time? And over time, this understandably becomes anger, frustration, and in many cases, withdrawal from care altogether. They lose trust in the system, and that can often lead to delays in seeking help the next time, even in emergency situations. And we see the clinical consequence of that. So sometimes rather than perhaps presenting earlier with subtle symptoms, it becomes an acute event when symptoms have become unmanageable. And then there's also the psychological impact of that health anxiety, which then exacerbates the underlying cardiovascular cause that the healthcare system was actually meant to address. And I want to just spend a little moment on this because I think it's all too often an afterthought. Being a woman is one risk factor for dismissal, living in an area of deprivation is another, but being a woman of colour is an additional indicator of dismissal. So, Black and Asian women face bias simultaneously. So, Black women in the UK are 2.3 times more likely to die in pregnancy than white women, and cardiovascular risk is a big part of that story. Our research base is not good enough. Cardiovascular trials have historically under-recruited women of colour, and our risk calculators are predominantly derived from white populations. So the absence of data itself is a form of dismissal, and the history of racism within the healthcare system reduces willingness to seek help or persist. And so trust really has to be earned before individual consultations can be effective. So much of what drives dismissal is systemic. Appointments are too short for maybe atypical or prolonged symptom patterns. So in the UK, for example, an appointment with a general practitioner is 10 minutes. In addition, sex-specific training is deprioritised. 60% of GPs in the UK say that they don't have enough time to adequately assess patients during their appointment. Guidelines still have gaps for cardiovascular presentations that predominantly affect women. And there was one study that looked at adverse pregnancy outcomes like preeclampsia and gestational diabetes that have an impact on cardiovascular risk late in life. And most GPs and cardiologists didn't build this into their routine risk assessment or counsel women who'd had preeclampsia about their heart risk. But 90% of them wanted more education in this regard. And then we've got unconscious bias, which continues to shape who gets referred and how quickly. Global Heart Hub have highlighted in previous reports that women with heart valve disease are far less likely to get the assessment and interventions that their white male counterparts do. And we know how women's pain has historically been rated lower by clinicians. And so these aren't just problems with one or two people in the healthcare system, it's a problem with how healthcare is organised. You might have heard the 12-second statistics that doctors interrupt a patient 12 seconds after they've started speaking. There are some studies from Eastern European countries which shows this is 28 seconds, but there was a small audit done in the UK which showed that people presenting to primary care, 88% of patients managed to complete their opening statement with an average of 47 seconds before the GP spoke. And about 80% of patients managed to get their symptoms and point across within 5 minutes. And what was interesting was that the more junior a doctor was, the quicker they were more likely to jump in. Again, highlighting a need in how we educate and train our healthcare professionals and giving people time to explain to us what the problem is, not interrupting them too quickly so that their main concern can be heard. And I'm sure there will be lots of healthcare professionals on the call as well. And so, how do we approach women on that first contact? Well, really allowing time for them to finish their statement, tell us what's wrong, and rather than use a pause or to kind of jump in and take over, encourage the woman to keep talking. Go on, I can see this is worrying you. And then summarise what you've heard. The ideas, concerns, expectations is built into medical education where we ask people what they think might be wrong. Some people don't like being asked that, but it's good to understand what we think people think they're presenting with, to listen to their concerns and then to ask what their expectation is from that consultation. Sometimes, though, that can become a tick box exercise where we ask it, but we don't truly listen and then let that help shape what we do next. And so, again, it's just taking a step back and thinking about how we consult with women to see if we can improve on this. And then we have approaches for professionals during the consultation. Can I just say, have my slides been progressing?
Sorry, Maggie. So you're on approaches for professionals, bias-aware
Oh
clinical
yeah,
reasoning?
that's fine.
Yeah,
That's fine. It just paused for me a wee second there, so I wasn't sure. That's okay.
no worries.
So this bias check is quite a powerful tool, and asking ourselves the question, would I respond the same way if a man was sitting in front of me, or an older person was sitting in front of me, or this person was from a different background? Not as a kind of self-punishment for the healthcare professional, but as a genuine clinical calibration. The Global Heart Hub report that was just published as well encourages a think heart first mentality. So, for women presenting with new symptoms or worsening symptoms of breathlessness, chest discomfort, unexplained fatigue, or atypical pain, thinking about heart as a cause for that. And then again, building in these things like adverse pregnancy outcomes, timing of menopause, into our clinical consultations and thinking about what that means for the woman in front of us. And then towards the end of the consultation, being explicit about what we think may or may not be happening. It's okay to tell a patient in front of us that we're not sure what's causing the symptoms, what we think it might be, but then what we're going to do about it to try and get that answer. That also helps to build trust, and implies that we're not just dismissing people because we don't know what the answer is. Using ask, tell, ask to understand if the woman has understood what we've said to them, and if not, reshaping it. And then agreeing next steps. So I'm going to do this. If things change while you're waiting on your investigation, please let me know so we can escalate things more quickly. And then ensuring that there's time for questions afterwards. And then what about for women and the public? So really thinking about before the appointment, what exactly do we want to get across? Can we quantify what's going on? So what symptoms do we have? How often are they happening? How long do they last for? And an important one is, what impact do they have on my daily life? Write down your top 3 questions and ideally bring someone with you, because it's always good to have an extra set of ears to listen to what the doctor's saying or to help us tell our story. And if your symptoms are worsening, don't wait for your routine appointment. Pick up the phone and ask for an appointment. And this is obviously relating to planned appointments that we know sometimes we become unwell urgently. And so having an idea about how to express types of pain, how we're feeling, how it's different to normal, are really good skills to have for any type of healthcare consultation. Try and lead with your most concerning symptom up front and use clear language. Describe how it feels as it changed from before if you have a thought about what it might be. In Scotland, we encourage patients to ask 5 key questions about their plan of care. So, is the test or treatment needed? What are the potential risks or benefits? Are there alternatives? And what would happen if I did nothing? And if you don't understand what's been said to you, please ask for it to be explained differently or in a different format. Or if the language you're engaging with the healthcare professional in isn't your native language, ask for the help of translators, because we know that that makes a big difference. And then if you feel like you're being dismissed, there are some steps you can take. And I know that these are difficult if there is a kind of power imbalance in that consultation room, but ask for your concerns and the outcome to be written down in your notes. Ask that you're copied in to any clinical notes so that you can see what's being discussed about your care. And request a follow-up with a review date. So if you agree to go along with the plan for the healthcare professional, request a follow-up to see if that's actually worked. Ask specifically what would need to change for them to investigate things further or have a different view on your presentation. And it's always okay to ask for a second opinion. In some places, this is now backed up by law. And so don't ever feel like you can't ask for a second opinion and you need to just deal with what's in front of you, because that's not the case at all. Good services are designed for people who use them, not for them. And so involving people with lived experiences in how we design services. And if you are a woman with cardiac disease or concerns about it, helping, being in a position to put yourself forward to help tell healthcare professionals to help them design systems and services. We also need to remember that a significant amount of the population are functionally illiterate. So 20% of Europeans have functional illiteracy. In England, 43% have low health literacy, and that figure gets higher for people with chronic conditions. And so ensuring that the information we develop for women with heart disease or at risk of heart disease is co-designed with women, make sure that the resources we design and put out there are actually useful for them. And from a healthcare professional point of view, we need education reform. Teaching is still largely built on male symptoms and patterns, and this can obviously contribute to why women's symptoms get mislabeled as anxiety or stress. And so we need sex-specific training to be mandatory and not optional. And this isn't just about doctors, this is all healthcare professionals. We also need to more openly talk about bias awareness as a clinical skill and ensure that when women talk to us, we validate their presence in front of us. We tell them that we believe them and that we will try and get to the bottom of what they're presenting with. And these are just two examples. So we've got the Canadian Women's Heart Health Education course designed for medical professionals that cover the spectrum of heart disease. And then on the right, we've got an example from Chest, Heart, Stroke Scotland, which is an online module for the public and for healthcare professionals about women's heart health. And so at system level, we need to make sure that women's heart health needs are named as a priority in policy and performance frameworks and not as an afterthought. Gender and sex-specific education needs to be embedded across the workforce, and we need to ensure that life course touch points from adolescence, pregnancy, menopause and beyond are integrated into cardiac prevention. Guidelines and tools need to be co-designed with women with lived experience, and dismissal should be treated as a safety issue, not as a bedside manner problem, because it does cause harm. And so just to finish, key messages from the Global Heart Hub policy document that was published really highlights the need to prevent dismissal, start by listening to women, understand their symptoms, partner with women and look at the systems that we develop, think heart first, listen without bias and design care that reflects the lives of women. And so just finally, this is a current UK research study funded by Heart Research UK with the Jane Lind Alliance, looking to find out what the main research priorities are for women's heart health. And it would be great if you were able to contribute your feedback to that. Thank you.
Thank you very much, Maggie, for such a comprehensive and informative presentation. You've given us some really crucial insights into the challenges people, particularly women, face in regard to dismissal. I'm now excited to introduce Hyvel and Renata, two incredible advocates we are so grateful to have with us today. Perhaps, Hyvel, you could start by introducing yourself and discussing what dismissal means to you and your experience of it.
Yes, I'm grateful to be here. My name is Hyvel, and dismissal is really concerning for me. I would say about 12 years into my journey, I didn't understand what I was facing. And going through a heart attack, a stroke, a second heart attack, and quadruple bypass, and to be sitting on a cath lab 12 years later, I understood that my journey was not for me alone. I was dismissed and denied and almost died because of it. And so going through everything as far as understanding healthcare systems do exist and there's such a bias. And instead of getting, I was really concerned about the treatment. Knowing what I know now, it's different. So I founded an organization because my story was not one of isolation. We hear it in our areas, we hear it in our neighborhoods. And the statistic shows the fact of we as African American women, women of color, denied, dismissed. And so I formed an organization to address the needs of our community to help save my life. But I understood that the calling was greater than I was because we needed to talk and not only be heard, we need to be believed of symptoms that would dismiss at initial cost. So that's why I speak for the voiceless to believe.
Thank you, Hyvel. That really contextualizes some of what Maggie introduced to us in her presentation. And Renata, perhaps I could ask you to introduce yourself as well and discuss a little about what dismissal means to you and your experience of it also. Sorry to interrupt you, Renata. You're just on mute.
So sorry.
No
Thank you for
problem.
the warm welcome. My name is Renata. I live with hypertension, elevated LPA, and ANOCA, angina with no obstructive coronary arteries. And for 25 years, my symptoms were dismissed. I've had many unnecessary tests. I've had a camera in my esophagus. I've been told it's anxiety, stress, hormones, anything but my heart. So nobody thought heart first. And that experience taught me I had to speak up and think about, well, other people are being dismissed as well. So I became active. I'm now a board member of Stichting Vrouwenhart. I am also active as a patient advocate for FH Europe Foundation and Global Heart Health because I think the experience taught me how important it is to be prepared, to keep looking for the right expertise, keep pushing for answers when something doesn't fit. So I'm very happy to be part of this discussion today, and I hope some of the practical things that have helped me will maybe help others.
Thank you, Renata. And I'm sure, I'm devastated to hear that you've had 25 years of dismissal, but I'm sure from that, you have a lot of tips and strategies to help others who experience dismissal as well. Perhaps you might talk a little bit about that. So I've heard you previously talk about how you prepare for appointments. Can you share what being prepared looks like for you, and what it looked like in the past when you were trying to seek answers?
Well, for me, being prepared meant making sure that the information was clear and easy to use. So I always thought, well, the doctor doesn't have the time, doesn't have all the information in front of him. That's what always my assumption was. And I always thought, well, they don't have the time to go through everything in detail. So every appointment, I bought my medication list, my relevant history. I've had preeclampsia in the past, so I knew that was relevant. I have very high blood pressure. I knew that was relevant. I took my blood pressure readings, notes on my symptoms. If symptoms had been going on for some time, I would also note patterns, what made them worse, how often they happened, and how they were affecting me in daily life. And I wrote down the questions I wanted answered. Preparation for me is about making the appointment work. And you do need the right healthcare professional in front of you. You do need someone who is willing to listen. So not that has not always been the case for me. And for me, then when I thought, well, then I'll have to look further. So I did my homework. I had read about women's heart health, and that helped me explain more clearly when I thought, well, these explanations I'm getting don't fit, and why I felt further investigation was needed. And later on, it has been mentioned already after my diagnosis, I found the brand model very useful. What are the benefits? What are the risks? What are the alternatives? What happens if you do nothing just for now?
Mm. Very interesting. It seems like you've had to rely a lot on your own resilience, your own health literacy and agency to get to that point of reaching a diagnosis. Hyvel, perhaps you could weigh in here with tips or tools that have helped you personally manage or overcome moments where you've felt dismissed.
Yes, thank you for that. I'm just going to piggyback on that. First, we have to trust our bodies. And if something does not feel well, you ask questions. It's so important. You live in your body every day. So don't take a dismissive or the wait and see approach. It doesn't work. If you're concerned, act upon it. And I feel like advocacy is such a big thing, especially in our community, where you go to a doctor and they may dismiss you or deny your symptoms, but you know your body. So ask questions. And asking questions and prying beyond just initial conversation with a doctor, it's important. So don't even feel, even if you don't get the right answers, truly ask other questions. If you don't like what a doctor is saying, seek additional options or second care. And, make sure and advocacy comes with a responsibility also, as far as understanding who you are and then, speaking up for yourself and doing the work. I created a care team, which is so important because I knew that I was not in this alone, nor did I know the verbiage or the language about going to see a specialist or getting a referral or what type of medications. So inviting your entire care team, the doctor, the cardiologist, the pharmacist, even a nurse into your ecosystem so that now you can build your knowledge and work that way, which is so
Mm.
important.
Absolutely. It's interesting. You both have two different stories, but there's so much synergy in what you're both saying and the actions you both think are needed. Renata, perhaps you could share what finding a doctor that was the right fit for you looked like. How did you go about seeking a second or a third opinion after being dismissed for so long?
Well, I went to five cardiologists in the end, so it was a long road. And for me, what really helped was looking into women's heart health myself, looking into the guidelines, finding help online, finding help with Stichting Vrouwenhart. They were doing interviews with cardiologists at a certain point. So I was able to research for a cardiologist who had a good working knowledge of women's heart health and go there. And that made all the difference because instead of fighting to be believed, there was a sense of I'm being heard. And finally, we could look at, okay, and now we can focus on my care and medication and going forward. So that was a really big step.
Hmm. That's really great insight there. Thank you so much. And Hyvel, for those who've lost trust in their healthcare providers or in the healthcare system after being dismissed, what would you suggest to help them navigate healing from that process in order to protect their health in the future?
That is so important. We understand that events do happen, but it's so important that we build an ecosystem because knowing that, there's different options also, social determinants of health. It's not only basically physical, it's, how you live, your community, who you surround with. So in our area, or the people we service, the women in our community, there's a plethora of different gamut of experience, their experiences. It's not only a heart condition, it may be comorbidities, diabetes, hypertension, it's in other ailments. So how do you bring a person that's dealing with a lot of stuff and also social determinants to now care and play a role in their health? It's fairly impossible. But I believe that's why we created Heart Sisters, an ecosystem where women are free to talk about the relevance of their experience and bring them from a place of not knowing to now empowering them to understand and take, it's all about prevention. When I found out that heart disease are 80 to 85% of heart attacks, 80 to 85 preventive, I knew that we can save women in our lives in our zip code right today with understanding, taking accountability, but moving from a place of not knowing now to bring the information, which is relevant, culturally relevant. So now it's people like us taking more control of our own health and addressing those issues one step at a time.
Yes, it's incredible to hear the role of the patient organization coming in there when we look to the future and look at prevention as well. Renata, I might jump back to you. So you've mentioned before about asking for a summary at the end of the appointment. How have you utilized that and why has that been so important for you along your journey?
Well, that's been very important for me because what's clear for the doctor isn't always what's clear for the patient. For the doctor, this is one appointment, right? In many appointments, in a busy day, and the language they use are normal for them, routine, obvious. But for me as a patient, I've waited for that appointment. I've prepared for that appointment. I have only a short time to make the most of it. So for me, a summary is a very practical thing. It helps me make sure I understand what the doctor thinks is going on, what the next step is, whether anything is changing, and what I'm supposed to do after the appointment. It helps avoid misunderstanding. So I think just asking, could we please quickly summarize the plan before I go, is completely reasonable.
Hmm. Absolutely. And in just a moment, we're going to invite Maggie onto the panel as well. But before we do, if someone were to come to you today and say, I'm really being dismissed right now, by my healthcare provider, what would be your elevator pitch of information to give them to address this? Your real top line key message. Perhaps Hyvel first.
Yes, I wanted to jump on it. Says, yes, yes, can I talk? Because it's so important. We wrote a brochure that says, with every Black woman should know go into the ER, which is so important because once you feel dismissed, you build up a, kind of like, should I talk or should I speak a certain way? Am I being combative? Am I being non-compliant? In our community, this is something that we struggle with every day. The biases that exist when we go to see our healthcare. Does he have a notion of what we're going to do? Is the medication towards adherence or is it over medication? So it's a lot of stuff that plays a role in that conversation with that PCP and gaining trust. And, in our community, there is a stigma with mistrust in our community. So how do you navigate this ecosystem that's really not built for us?
Mm.
It's making sure that you're heard, making sure that your points are valid, and coming from a place of, I want to save myself. How do we do this together? And it's something that we've dealt with and we understood. So we're meeting the needs of our people or the people we service by understanding we're dealing with an ecosystem that does not work for us. Now, how do we navigate it so that we can be part of the playing field? Because at the end of the day, we all want to go home. And, building that relationship with a doctor is critical, making sure they understand who you are and a place of care, compassion, and empathy, which is a major issue in the people that we service.
Mm. It's great to hear you highlighting some of the existing resources from organizations like Heart Sisters, and how we can utilize them before or during dismissal as well. Renata, perhaps I pose the same question to you.
Well, I think while my symptoms kept getting worse and I kept being dismissed, I kept looking for more information, and I found it. It is there. There are patient groups like Stichting Women Heart, like Heart Sisters. There are lots of groups available with information that can help you. And also, it became very clear to me that I could easily walk out of an appointment with no real answer, no clear plan, no progress. So I became more direct. Could you explain that differently? What exactly do you mean by that? And if I still didn't understand it, I'd ask again. And I'd ask for a referral. I'd ask for that second opinion. I knew what was happening. I knew I was being dismissed. I knew there was an undertreated, underdiagnosed, under-researched aspect being happening there. So I became very, very concerned and very direct.
Mm. Thank you both for sharing there.
Can
I'd
I
like to
add
invite,
something also, which is
absolutely,
so
please
important,
do.
especially when a woman is going through this issue? It's so important to bring your family members. It's so important to get validation, so important. So if you have that appointment, invite a friend, invite your care partner, invite your husband, invite someone can be a relevant support, which is so needed because isolation is not a place where you want to be. So if you make it where you have an ecosystem of care or provider that can help you out in the system, that is so important.
Mm. Absolutely. And actually, I'm going to invite Renata to jump in here as well, because I know this is something that you're quite passionate about as well, Renata, and a tool you've utilized.
Yeah, I've always bring someone. I always tell the other women, bring someone with you because appointments are short. A lot of information is covered, and it's easy for important points to get lost. Plus, it helps to have a second pair of ears in the room, but also afterwards you can compare what you heard. But it also changes the dynamic in a very useful way, I think, because it makes it much easier to ask questions and sometimes just to say, "Oh, actually, that doesn't answer my question." Because there's someone else in the room. Gives you that support. It wasn't ever about not coping on my own. It was about making the appointment more clear and more effective.
Mm. Thank you both. And Maggie, you're very welcome back to the panel. I'm going to jump straight over to you. So given the work that you do and your advocacy, I'd imagine, unfortunately, Hyvel and Renata's stories don't come as a surprise to you. More a contextualization of some of the things you've discussed. Do you feel there's a gap there where there's a lot of providers who maybe don't understand that they are dismissing someone due to those systemic gaps that you alluded to?
Yeah, absolutely. I mean, there will definitely be personalities out there that are, not the type of people you want to see in healthcare. But for most people, they would probably be mortified if you fed back to them that you felt dismissed or they weren't listening. And so, and we try and seek to kind of to change that to really to listen to you and take things forward. So I think for most people, it's the structure, it's the system. It's well evidenced, especially the people who do experience it, who are more likely to be dismissed. And we've already kind of covered that. So I think it's about, as healthcare professionals talking about it, we're starting to talk about it in professional spaces. It's now part of conference programs. We're trying to embed it more in healthcare professional education because the worst thing we can do is know about it and not share it with each other professionally. So that's really important. But we also need to look at the structure of healthcare and how that contributes to it. So time is an issue. If someone comes with lots of health problems already, the symptoms are maybe hard to determine what the main cause is. it's very easy to then put it down to something that already exists rather than investigate something new. So, and often, like I said, when we design these services, it's about output. How many people can we see? Can we keep the waiting list down? They're not designed to get the best out of that patient professional consultation. And so looking at the system, looking at the structure, bringing in women and other representatives to say, what do you need when you're in front of a doctor or a nurse or another healthcare professional? How much time do we need? And what pathways do we need to put in place so that that healthcare professional, even if they're not entirely sure what's going on, knows someone else that they can then go to for advice?
Mm, absolutely. I think this underscores the importance of, communicating that you feel dismissed, though I understand it must be difficult to do. But there may be some providers who that stops them in their tracks. How can a patient do this? Is it as simple as saying, I feel dismissed?
So yeah, I think gone are the days where people sat in front of a doctor and just had a doctor knows best mentality. I think we're finally getting out of that mode where we just become active or passive participants in our healthcare. As individuals, we have a right to ask questions. And so I think, I saw someone do this in a clinic recently where I was there as a student and I could tell that there was a difference between what was being said and what was being heard. And they just said, I want to make sure I've communicated this clearly because I'm worried that you're missing something important, and they kind of started again and tried to redress it. As well, asking what makes the doctor or healthcare professional come up with that plan. Would the plan change if their presentation changed? And being really specific about saying I don't want to just go away and be left. Can I make a follow-up appointment just to make sure what the doctor suggests might work and it might be okay. But if it's not, having that safety net there of going back again is also really important. And don't be afraid to ask for a second opinion. It's okay to do that. No one's going to take offence. They might actually be quite grateful because they might be struggling to get to the bottom of what the presentation is. And it might be good for them to hear that you're also, would like that second opinion, and it could help enhance the care that you get. So please don't ever feel like you can't ask for a second opinion.
Mm. I'd like to dive a little bit into something you just said, and maybe I'll go over to Renata about, is there merit in writing down your symptoms ahead of your appointment so that you don't lose track of when things are happening or how they're presenting, and it helps you to really communicate that to the doctor?
Yes, thank you for that question. Yes, I think that makes things much more concrete because if you're sitting in front of a doctor and you're speaking from memory, especially when you only have 10 minutes for an appointment, it's very easy to forget details. It's very easy to not explain things clearly enough. And writing things down helped me be more clear about what was happening, when it happened, see patterns, what made it worse, how it was affecting me. And to say, well, this isn't all in my head. This isn't stress. This isn't anxiety. There's a real pattern here. And it helped because I could just show them for my notes. I guess this is how often this happens, and this is what I'm concerned about. And I want to echo what I just heard. It's really important to know it's okay to ask for another expert. It's okay to ask for a second opinion because sometimes you don't need an opinion, you need the right opinion.
Mm, absolutely. And hi Val, would you like to weigh in on the same?
Yes, I would love to add, there is a lot of technology that does exist. And, the fact of you can go to, in America, we have My Chart where you can actually go and take a look at your blood work. So, in the doctor's office, we have like 10, 15 minutes with the doctor's office. But what about you coming in with your own lab results? So you can have a frank discussion and have the doctor tell you what's going on. So you can start that conversation. So it's all about being the professional patient. Yes, there is such a thing. It's so important because, I want to live. Therefore, I need to do my own homework to understand what I'm doing with, benchmarks. When I was diagnosed with diabetes, I didn't even know what an A1C was. But once I knew what it was, I knew what the number was, I knew my aim, even with the new guidelines that just came out with the AHA in reference to cholesterol. Great. It makes it simpler. So even knowing, your blood work and knowing exactly which aim for benchmarks, what numbers your triggers, and arming yourself with a lot of knowledge, not only waiting for that doctor to tell you, but you can do your own research and now you can have a conversation with the doctor. Now it's more now of communication. Because I believe in a lot of these cases, it's a barrier of communication. So as a woman, go into a doctor, arm yourself with knowledge. Understand that when you go into that room with the doctor, you know what you need, you know where you're coming from, and now you guys can have a conversation on where you need to be. So it's a roadmap, but the homework has to be laid as fundamental on both parties, not only the professional, but as a patient, we also have an obligation to ourselves.
Yes, that's a great point. Thank you so much, Hyvel. And Maggie, I asked Hyvel and Renata to give their sort of elevator pitch. I'm going to pose the same question to you. So, from the healthcare provider's perspective, what would be your top line dream tools for a patient to bring to their appointment to prevent being dismissed?
So I think a diary is great if you can. Another person or ask to record because um, some appointments you've got no idea what's going to happen, particularly if you've had an investigation and you're going for the results. And the minute you hear what that result showed, everything else you can't remember properly afterwards. So either having another person or being able to record the conversation for afterwards. Um, Language to express yourself is really important, and I think that's where tools, reading materials, speaking to other people, maybe with similar conditions, although you have an individual experience, um, and just being honest about how you feel. You can't let yourself down in that room. You can't let the doctor down. You can't let the person who's with you down by expressing exactly how you feel and the impact it's having on your quality of life, particular. So just it's a safe space. Be honest about how it's impacting you because the impact on your life is a big marker for then what we do next or how urgently perhaps we do something next. So yeah, bring questions as well to ask, and write them down because, like we've said, it's easy to forget once you sit in that room in front of that healthcare professional. So symptom diary if possible, questions, another person or record it, and be honest about how it's impacting your life.
Thank you, Maggie. I'm conscious that there's just a couple of minutes left, which is unfortunate. This webinar has flown. I'm sure we could probably talk about it for another hour, but we have given our audience some really concrete tools and tips to utilize to mitigate, prevent, and address dismissal. So I'd like to thank our incredible panel for joining us and facilitating such an important discussion. Thank you as well to our audience for joining. I see there have been chat box comments. It's great to see you all interacting. I hope this session was as insightful for you as it was for me. You will receive a survey after this webinar, which I hope you take the time to fill out. We truly do take your feedback on board, and let's keep this conversation going. And for anybody interested in learning more about Global Heart Hub or for joining our community as an affiliate, if you haven't already, don't hesitate to reach out to me or mention it in the survey at the end. Thank you so much for joining, everyone, and have a great rest of your week. Thank you.
Thanks all. Bye.
Bye.